The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to our October Dementia Dialogues. My name is Heather Mulder and I'm the Outreach Senior Manager here at Banner Alzheimer's Institute, and I have the pleasure of being your moderator this morning. In 2018, we have been in a pursuit of answers through our dialogue series, where we've been tackling different questions related to the caregiving experience. And this month, we're taking a different tack, where we're going to be looking more into research efforts. We're going to try to answer the question, what is the latest in Alzheimer's research efforts? It is my pleasure to introduce to you our speaker today, Dr. Pierre Interio. Dr. Terrio is a Phi Beta Kappa graduate of Amherst College who attended the University of Rochester School of Medicine. He completed residences in internal medicine and psychiatry at the University of Wisconsin in Madison, Wisconsin, and is board certified in both specialties with added qualifications in geriatrics. He served as a fellow in the intramural research program of the National Institute of Mental Health. In 1986, he joined the faculty of the University of Rochester Medical Center. Since 2006, he has been at the Banner Alzheimer's Institute, where he serves as director. Dr. Terrio has investigated and lectured extensively on multiple aspects of diagnosis, therapy, and prevention of Alzheimer's disease, and has published over 250 papers on these topics. Together with his colleague and friend, Eric Ryman, he serves as the co-director of the Alzheimer's Prevention Initiative, an NIH-funded international program to study experimental therapies that may delay or even prevent the symptoms of Alzheimer's disease in people at highest imminent risk. He now has an appointment as a research professor of psychiatry at the University of Arizona College of Medicine and is a member of the American College of Neuropsychopharmacology and has earned several awards for his research. Welcome, Dr. Terrio.
Thank you very much.
Thank you so much for joining us this morning. And I have to say, I had to cut about half of this bio that I was reading so that we didn't fill the entire time reading all of your accolades.
Yeah, well, proud dad and granddad, I think that's the most important part.
We should add that to your bio.
Yeah.
Again, thank you so much for sharing some of your time with us this morning. I just want to dive right in because I know you have a lot of great information to share with our attendees today. And I want to start with kind of some of the recent news that's been coming out. And actually, when I'm out in the community doing presentations, many people are often surprised to learn that the FDA hasn't approved a drug for the treatment of Alzheimer's disease since 2003. It's really hard to believe that no successful developments have happened in the last 15 years. And the failure rate of experimental Alzheimer's drugs is above 99%. Can you explain what's the reason for these sorts of results, and how do these failures offer hope for success in the future?
Sure. Well, I'm a glass half full sort of guy. Let me come at it this way. The treatments that are already approved by the FDA are treatments that are designed to try to improve somebody's memory and other thinking ability for a while and protect against loss of memory and other thinking ability over time. And they do a pretty good job of that. We'd love it if we could do better. And trials are going on still with agents that have that kind of goal in mind. We frequently refer to those as symptomatic therapies. But since in the last 15 years or so, the scientists in laboratories all over the world have discovered a lot about how Alzheimer's disease unfolds in the brain, and that in turn has led to as many as 300 different experimental therapies that have been or will be put to the test, and a lot of those are designed to attack the underlying biology of the disease, in particular interrupting abnormal protein processing pathways leading to abnormal proteins called amyloid and abnormal proteins called tau. And you're correct, Heather, to say that a lot of these have failed, but it's not that we haven't learned from them. So some of the earlier failures, let's say 6 or so years ago, it turns out the medications didn't have a potent enough effect against, let's say, amyloid, because a lot of them went after that amyloid protein, or couldn't be given in doses high enough to attack that pathway. And so the anti-amyloid therapies have been refined, and we know for sure that they attack the biology of Alzheimer's disease. The trouble is, so far, we haven't been able to show whether treating people with these agents confers benefit. And probably the most current interpretation of the failures is that, at least for medications that impact this biological pathway, if they are given to people who already have extensive brain damage, it's probably too late. And so many of the efforts have switched to the earlier phases of the illness, what is sometimes called prodromal Alzheimer's disease, people who have very mild memory and thinking symptoms and have what's called a biomarker finding indicating that this amyloid protein is out of whack. So quite a few studies in that window, no later. And then groups like ours have mounted prevention studies out of the view that treating people who are at risk but who don't have any brain damage yet may be the best way to go. And a common analogy that's used is statins to lower cholesterol. It took a while to realize that the best time to use a statin wasn't during or after your major heart attack, but 20 years before. So the field has definitely shifted in that direction, and a relatively large number of prevention trials are underway, informed by this decade or so of, quote, failure. And I don't quite love that word, because in every case, we've learned valuable lessons. And so maybe I'll close, and I know you're going to probably press me further on this, but I'll close for now by reminding folks that the efforts to put Alzheimer's disease behind us is a marathon, not a race. So we will need multiple kinds of agents, multiple kinds of clinical trials before we get traction. So there's reason for cautious optimism, but as you say, a lot of disappointments too.
Mm-hmm. And I agree. It seems like, of course, whenever these study findings comes out, the media grabs a hold of them and it becomes sensationalized, and sometimes it's hard to stay positive. And I've always appreciated the view of Banner Alzheimer's that even though we have not won the battle, we still can win the war against Alzheimer's.
Yeah. I hope this isn't too technical an example, but if there are sort of experts listening, here's an example of a really important question. So how early do we go? So a lot of the clinical trials that are reading out soon are in prodromal Alzheimer's disease, as I mentioned, some mild memory or thinking difficulty and evidence of elevated brain amyloid. In the Alzheimer's Prevention Initiative that we help run, we've raised a different sort of question. Is even that too late? Should we find people who are at elevated risk, let's say because of their genetic makeup and age, but who don't have that elevated brain amyloid yet? So we've deliberately designed our studies to address that kind of question, and we just reported out that in fact we have enrolled that very kind of cross-section of people. So that's an example of the kind of progress we need to make. So our answers won't be rolling in for a few years, but they will come.
Mm-hmm. Very exciting.
Wish us luck.
Yes. So I appreciate the answer that you've given, because you touched on a lot of things that I'm going to bring up in these additional questions that I have for you. And so I know you mentioned already plaques and tangles, and we always hear of that as being the cause or the contributing factor for Alzheimer's disease. Can you explain the significance of plaques and tangles, and then how does that inform research?
Sure. Well, Alzheimer's disease is a disease that actually kills brain cells called neurons, prunes the connections between surviving neurons, and results in the accumulation of abnormally processed proteins as well as some other changes, but I'll focus on the proteins. And so this amyloid protein gets misprocessed, and what you get is clumps of misprocessed protein outside of cells that you can see under the microscope, these fluffy deposits called plaques, which is one of the hallmarks of Alzheimer's disease under the microscope. And then there's a different protein pathway that goes sour, the tau pathway, TAU, which is a protein inside cells that's used to kind of support the highway system, transporting nutrients back and forth within cells, for instance. And that protein also gets misprocessed, resulting in a different kind of visible formation inside cells that's known as tangles. And so the hallmarks of the disease are somebody has to have a dementia that looks and sounds like an Alzheimer's process and has to have these features visible under the microscope. And as I mentioned a minute ago, thanks to brilliant work by scientists all over the world, we know a lot about how these features develop. And one of the exciting things in the field is exploding information about how tangles form and how quickly and why and when. And there seems to be this elaborate dance between the amyloid misprocessing that occurs that gets to a kind of a tipping point, and then all of a sudden the tau and tangles get unleashed. And interestingly, the amyloid plaque burden does not correlate with degree of cognitive impairment, but the tangle burden does. And so somebody listening might say, well, then why on earth do you even go after the amyloid? There's pretty compelling evidence from genetics and from experiments in the lab showing that if you stop this amyloid process early, you can preclude the whole tangle pathway. And that's supported with dramatic evidence in humans because there's a human mutation that actually blocks amyloid misprocessing from birth. It's called the Icelandic mutation. These people, for all practical purposes, never get Alzheimer's disease. So that strongly argues for trying to interrupt this amyloid pathway. But at the same time, I'm delighted to report that there are now also anti-tangle strategies in clinical trials. And it's very exciting to understand that we've gone from not having these to having several in clinical trials just in a couple of years. And the way you've phrased the question tees up a probable future approach, which is combination of anti-amyloid and anti-tau. So again, it's a marathon, but I think people who do this work still have this sort of sense of patient, cautious optimism that we'll get there.
I have never heard of the Icelandic mutation before, and so that, can you explain that a little bit more?
Sure. There's a very rare mutation in the gene that controls the creation of the amyloid precursor protein. And that mutation reduces but doesn't block the activity of one of the, it's called an enzyme, it's sort of a pair of chemical scissors that causes abnormal processing of the amyloid precursor protein. That enzyme in-house is known as BACE, B-A-C-E, has a fancy long name that I won't get into. But if you block that enzyme, you don't get the bad form of amyloid. Well, this mutation reduces the activity of that enzyme by about 20%. And so what that indicates very, very strongly, and it's mimicked in animal models, that if you reduce the activity of the enzyme that creates the bad form of amyloid from birth, you're virtually protected from the disease. So that alone says that we must try anti-amyloid therapies. But which agent is best, and how early do we need to go?
And can you explain a little bit more? You mentioned how you see the plaques start to accumulate first, and then the tangles start to come, and that's then when symptoms start showing?
That's about right. There's dramatic new evidence, including some brand new papers just in the last couple of weeks from our colleagues in the dominantly inherited Alzheimer's network, who've been able to do longitudinal brain imaging studies looking at amyloid and tau in the brain with this type of imaging technique, showing what you just summarized accurately. So this is pretty exciting. Exactly what causes that tipping point isn't clear, but it's increasingly clear that that's kind of what's going on, and that the uptick in tangle burden is, in the scheme of things, relatively quick.
Very interesting.
So can we stop that from happening?
Right. And when? As you said, when do we stop it?
Yeah.
So next I wanted to ask you about biomarkers, and you've mentioned this a couple times already. Recently, philanthropist Bill Gates and the Alzheimer's Drug Discovery Foundation announced a new initiative to develop biomarkers for the early detection of Alzheimer's disease. Can you talk a little about how these biomarkers would be a game changer in the fight to end Alzheimer's?
Well, do you have an hour and a beer?
Well, I just happen to.
It's 10:15, Heather, in the morning. So biomarkers are absolutely a game changer, and let me try to be concise about why that is. Certainly, if we have better measures of how the biology of Alzheimer's disease affects the brain, we could improve diagnosis. That's a real plus. And let me just go there for a second. We are in striking distance, I believe, of blood-based biomarkers for diagnostic purposes. Most people don't know that, but boy, behind the scenes, labs are racing to the finish line for that kind of technology to be routinely available. So diagnosis is a big deal. Understanding the disease is a big deal in ways that I've just described about these PET scans for amyloid and tau. But if you think about it, where we'd like to go in the future is, can a biomarker, that's one biomarker, tell you whether somebody will or won't respond to a treatment? That's called a predictive value of a biomarker, and we in the Prevention Initiative are doing that kind of biomarker development. Will a single measure tell you whether Joe will respond well or poorly to a treatment? Also very important is, will a single biomarker or a biomarker profile tell you about your future? Will you be somebody who remains relatively stable over the next 10 years, or do you have a profile that indicates that you might change very quickly? And then lastly, and this is maybe the most important goal of biomarker development, in my personal opinion, is can we get to the point where we know that a change in a biomarker over a short period of time tells us whether 5 years down the road I will have a clinical benefit, so that we can start doing biomarker drug development studies in a small number of people in a short period of time and make very rapid go, no-go signals, or obtain very rapid go, no-go signals. And that is a fancy term. It's called theragnostic biomarker. But wouldn't it be nice, back to cholesterol, wouldn't it be nice if we had a test available that predicted good response, but also could predict, yes, 5 or 10 years from now, your cognitive function will be much better with this treatment than without. Kind of like a statin. Cholesterol is used to decide whether or not to use a statin. So game changer for sure.
Absolutely. It sounds like it can be predictive, it can be diagnostic.
Prognostic and theragnostic. How about that?
Oh my! We'll have to look those words up after this.
And I realize I've left something really important out. I'll again try to be more concise here. Also, assessments of memory and thinking could be viewed as biomarkers. So we're also in striking distance of really brilliant study results that will inform us whether the data, for instance, on our iPhone could tell us whether we're starting to suffer impaired brain health, and therefore prompt earlier attention and also be used as a response measure for treatment. Things like that.
How exciting.
Yeah.
So many different avenues
Yeah.
are being affected by biomarkers.
Yeah.
So you've said striking distance a couple times.
Mm-hmm.
Can you elaborate on what does striking distance mean in the world of research?
For instance, for the blood-based biomarkers, I'd be shocked if they're not being widely deployed within 2 years.
Wow.
For these other ways, for instance, they're called passive assessments of cognition and function, maybe more in the realm of 4 or 5. But just for instance, how your eyes scan a computer screen can tell you an awful lot about brain health. Another example is when you walk, how fast you walk says a lot about your brain health, or how consistent or inconsistent your stride length is tells you an awful lot about brain health. So these are just some examples.
Wow.
Yeah.
I had no idea.
Yeah.
So along those lines, I wanted to move to our next question where I wanted to talk about the preclinical phase of Alzheimer's, because we've mentioned this a few times. And when you talk about prevention research, we talk about attacking the disease in its preclinical stage before any symptoms are present. Is this plaques or tangles, or how do we identify the preclinical phase in someone?
And I don't know if that's the
I
screen
apologize.
people are looking at. Preclinical is kind of a technical term that's been adopted by health authorities like the Food and Drug Administration, who, by the way, have been amazing partners in all these efforts to diagnose, treat, and prevent Alzheimer's disease. So it refers to somebody who has no evidence of impaired memory and thinking ability, but is known to be at high risk for some reason. And those known to be at high risk things include if you carry a specific genetic mutation, which is rare, but it happens. We can identify those people through genetic testing, and we've done so, for instance, in South America. And so people like that are in preclinical trials in Colombia, in a trial that's going very well, by the way. Then, as I think you know, Heather, the most common genetic risk factor for late onset Alzheimer's disease is a gene variant, not a mutation, called ApoE4. And so if you carry 1 or 2 copies of the ApoE4 variant, you are known to be at elevated but not certain risk of getting Alzheimer's symptoms. And then a third way to identify people at risk is with biomarkers. PS, the biomarker we've been using, may identify people with normal memory and thinking who are at elevated risk because of the presence, for instance, of elevated brain amyloid. But we may be learning that even that may be a bit too late, so we may need other biomarker vulnerability measures.
Okay.
And then if we're starting to develop measurable difficulty with memory and thinking, that's somebody else who's going to be vulnerable.
Okay. And transitioning into now the question that we're looking at, and you touched on gene therapy, what genes play a part in the development of the risk of Alzheimer's, and how are those going to be used in the future?
Yeah, so I don't want to profess to be a gene therapy expert, but let me begin with a note of caution that monkeying with genes, human genes, in an effort to treat is a very difficult undertaking. there are ways to edit the genetic message. Some people have heard about CRISPR, this sort of scissors that can excise specific chunks of the genome. But we're learning already that even if that's done, the genome tends to come up with new problems anyway. So the fact that we have genetic determinants of Alzheimer's disease, these mutations, does hold the promise of possible future genetic modification in adults who can't bear children, if they are fully informed about risks and benefits. I will tell you that my personal view is that that could be decades away. Decades away.
Okay. And we just have a couple minutes left with you this morning, Dr. Theriault. Any final thoughts that you would like to share to kind of summarize where are we headed in the world of Alzheimer's research and even more specifically prevention research?
Well, so, just to enumerate some of the prevention trials. So there is the trial in Colombia, South America, the Alzheimer's Prevention Initiative, autosomal dominant Alzheimer's disease trial, where we are immunizing people as young as age 30 who have normal memory and thinking, but carry these mutations that cause them to develop Alzheimer's dementia with certainty in their 40s and 50s. So that trial is going well. That's public information. The quality of the data is excellent. We will get answers. It'll still be a few years. It's 2022. But we'll get answers. And we'll get answers about, gee, does it matter whether amyloid is already elevated in the brain or not in these kinds of people? Then the next two Alzheimer's prevention trials are underway globally in people who are 60 to 75 years old and carry either one or two copies of this ApoE4 gene. That's called the Generation Program. If people want to look into it, they can get information from the Alzheimer's Prevention Registry or generationprogram.com. Those studies will be enrolling thousands of people worldwide. Our colleagues in the Dominantly Inherited Alzheimer's Network have funding to do preclinical trials and plans to initiate them. The so-called A4 study is a trial in unimpaired people who have elevated brain amyloid. So a bunch of these are going, and there are more to come. API just received another grant to launch a fourth prevention trial. We may need 10 before we get the kind of answers we all dream of. But in the meantime, I want people to understand that we're also not giving up on things sort of closer to the ground. Can we help people already affected with new and improved treatments? And Heather, as you know very well, we're also committed to efforts to improve the diagnosis, medical treatment, and support people in daily life who are already affected.
Right.
And that's a big deal too.
Definitely. Thank you again for your time this morning, Dr. Theriault. I think this was a really valuable peek into the world of research that people don't often get. And so I appreciate you sharing your knowledge and your expertise with us this morning.
Thanks for the invitation, Heather.
Yeah. I want to invite our attendees to join us next month, where we're going to be talking about wellness. We're going to be tackling the question, how am I supposed to fit in self-care when I don't have a minute to spare? Thank you all for joining us this morning for our October Dementia Dialogue. As a reminder, as the session closes, you will be emailed an evaluation. Please do take a couple minutes to fill that out and let us know what you thought of today's session and also what you'd like to learn in the future. Today's session has been recorded and it will be housed on our website for you to reference in the future within 48 hours. Thank you for attending Dementia Dialogues, where we bring the dementia education to you.